Hi, welcome to NEET PG Core Revision series in Pharmacology, where I will be discussing the important topics for the upcoming NEET PG examination. So today we are going to talk about hypolipidemic drugs. So first we should know the desirable levels of the various lipids. So we have for the cholesterol, triglycerides, LDL, HDL. So there's a simple trick to remember this, like for cholesterol, start from 200. So the desirable level should be less than 200 milligrams per deciliter. Now just keep on subtracting 50. So for triglycerides it should be less than 150. LDL should be less than 100. Now in women, the HDL is a good cholesterol in all, we know that. So it should be, the level is 50, remember, minus 50, but it should be greater sign. For men, it should be greater than 40. Right? So these are the desirable levels. So then only if in exam they give you these values, you can come to know whether it is on a higher side or not. So moving on to now, the first question which was asked in the previous year. So which of the following drugs act by inhibiting the PCSK9 and is used for lowering the LDL cholesterol levels? So whether it is evolocumab, ezetimibe, bempedoic acid or clofeprate. So the mechanism, the PCSK9 inhibitor here is evolocumab. So this makes us think, or you can understand from this, that it is important to know about the various mechanism of action of these hypolipidemic drugs, because we are asked often in the exams, out of one of these drugs will be asked. So let's now go and further do the important points about these drugs. What are the important mechanisms, the indications or side effects? So the first and most important, we have statins. So statins, also called as HMG-CoA reductase inhibitors, because they inhibit the enzyme HMG-CoA reductase, right? So with this, they will cause decrease in the level of LDL mainly. Indication, they are a drug of choice for hypercholesterolaemia. Then they can be used for treatment or prophylaxis of in patients of myocardial infarction, in stroke, right? Especially if the patient has a high risk of, in the prophylaxis we can use if there is risk of atherosclerotic coronary vascular disease and the LDL is more than equal to 190. So for prophylaxis, definitely we should be using, or even in the treatment if we find the levels are high. So what to do here, because many a times this question is asked, if you're given that patient is at high risk of ASCVD and the LDL levels are 190, then what to give? You should definitely start a statin. Now which statin do we actually start here? So the statins which are called as high intensity statins, so we have two of them. One is rosuvastatin and atorvastatin. So remember, 20, 40, 80. Keep on doubling it. So this is the strength, 20 milligrams, 40 milligrams and 80 milligrams. So rosuvastatin, the dose is high intensity dose. Rosuva is 20 to 40 milligrams, and then 40 to 80 we have atorvastatin. Okay, so this is the dose of these statins. Side effects, important side effects to know here. The number one is that we should be worried about is myopathy. So they can lead to myopathy, which can lead to myoglobinuria. Number two, the other important is hyperglycemia. Hyperglycemia. So in a diabetic patient already, we'll have to be very careful there. Number three is hepatotoxicity. Hepatotoxicity. Now, these are contraindicated in pregnancy because these are teratogenic drugs. In children, in less than 10 years of age, we do not use them. So, contraindicated in pregnancy and in children less than 10 years of age. But we can use pravastatin. So, in children less than 8 years of age. Here, pravastatin. Okay. So, contraindication is pregnancy in children less than 10 years of age and in children less than 8 years of age, the pravastatin. is another important thing to know. So then going to talk about raisins. So before I go on to raisin, let's me discuss a little more about these statins because it's one of the most important groups here. So we have lovastatin, atorvastatin, simvastatin, all statins here. Now they are going to inhibit the HMG-CoA reductase we thought already discussed. So this is the HMG-CoA reductase here, the enzyme which is going to convert the HMG-CoA into mevalonic acid ultimately for the cholesterol. So this is important for the de novo synthesis of cholesterol in the liver. So what happens when you block this enzyme? The de novo synthesis of cholesterol in the liver does not take place. So when this does not take place, now liver is going to now try to get the LDL or to take the cholesterol up from somewhere outside. So what it does is, when it inhibits this, the LDL receptors on the liver here, they get upregulated. So they will get upregulated. So when these receptors, they get upregulated, definitely they are going to pick up more LDL from the blood. So what are they going to do? They are going to therefore increase the uptake of plasma LDL. So what will happen eventually? There will be decrease in the LDL cholesterol level. So about 20 to 55% decrease can be seen. So they are very, very good drugs for decreasing the LDL cholesterol. Yes, they also can decrease the triglycerides, but not majorly used for that. But some amount of decrease in triglycerides can be tried with statin as well. All right. Now the action, it takes about 1 to 2 weeks for them to act. So these are one of the best drugs for hypercholesterolemia. Now there are some other effects which are seen with statins, and these are called as the pleiotropic effects. So they have multiple other beneficial effects as well. And what are this? That they can cause decrease in the inflammation. They cause decrease in the platelet aggregation. They can cause decrease in the oxidative stress. They cause decrease in the uric acid levels. They decrease the risk of coronary vascular diseases. Then they increase the nitric oxide production. So these are the various beneficial effects that you can see with statins. Now, some important one-liners about them. So which is one of the most efficacious statins? So I've already discussed that. That is rosuvastatin and atorvastatin. Atorvastatin. Prodrugs, lovastatin and simvastatin. Most potent, pitavastatin. So pitta is more potent. Longest acting statins. So most of the statins should be given at night because the production of this HMG-CoA reductase enzyme, they are more efficient at night, except for the longest acting, these statins can be given at any time. So longest acting ones are rosuvastatin and atorvastatin. Least drug interactions. So out of them, pravastatin, it has no CYP metabolism. Therefore, it has least number of drug interactions. So also this is a safe statin for liver disease. It doesn't follow the metabolism in the liver. Another least drug interactive statin is rosuvastatin. Now we move on to the second group of drugs here that we have. That is your raisins, bile-acid binding raisins, which we have is cholestyramine, cholestyramine and cholesevelam. So what they do is they interfere with the enterohepatic cycling of the bile acids. So they do not allow the bile acids to recycle. So again, there will be, you can say that they are required for the cholesterol synthesis. Again, there will be decreased cholesterol synthesis. So the similar pattern they follow. Because of the decrease in the cholesterol synthesis in the liver is going to try and increase the receptors on it, and this is going to take up the plasma LDL, and hence there will be decrease in the LDL levels, right? So this drug raises, again they are doing the same work as statins, but where do we use them? We use them in case of hypercholesterolemia in case of pregnancy, because statins are contraindicated here. So in case of pregnancy and children, we will prefer to use these drugs. What are the major drawbacks here? They can cause increase in the triglyceride levels. They can cause constipation. And not only the bile acids reabsorption suffers, they also can decrease the absorption of other vitamins. So deficiency of those vitamins can occur. Okay, so moving on to the next drug group that we have, that is the fibrates. So fibrates, we have fenofibrate, gemfibrozil, and we have one another, bezafibrate, right? So what are these? These are PPAR alpha stimulants in the endothelial cells. So what is the role of PPAR alpha in the endothelial cells? They are going to, when you stimulate them, they stimulate the lipoprotein lipase. The role of lipoprotein lipase in the endothelial cell is to cause degradation of the triglycerides. So when they stimulate this LPL, more of triglycerides will be broken down. So they are going to bring down the levels of mainly the triglycerides and then also of the VLDL. So their main indication is hypertriglyceridemia. So their drug of choice for hypertriglyceridemia. Okay, side effects, very important. Their main side effects, number one is myopathy, especially more common with gemfibrozil. Therefore, gemfibrozil is never recommended to be given along with statins, because statins also cause myopathy. So both, if you use them together, they will have more of myopathy. As compared to this, fenofibrate is safer. You can give fenofibrate with statins. Number two is that they can cause gallstones. Then we have niacin. So niacin in high dose is used as a hypolipidaemic drug because it inhibits the lipolysis in the adipose tissues, right? So lipolysis is inhibited and it decreases the synthesis of LDL basically, because then it is no longer available for the formation of the LDL. Now this niacin has another property that it can cause maximum increase in the HDL levels. So this drug causes maximum increase in the HDL levels. So where do we use them? In case of dyslipidemia, especially with increase in the decrease in the HDL levels, right? But because of this high dose of niacin, a lot of side effects also occur. So major, number one side effect is flushing. Now this flushing is because it can cause increase in the prostaglandins. So therefore, what is the treatment of flushing? Is either you give a prostaglandin synthesis inhibitor like COX inhibitor, we have aspirin. And there is another drug which is called as laropiprin. This is a prostaglandin receptor antagonist. Prostaglandin antagonist. So it is PR, prostaglandin antagonist. So these two. Number two, it can cause increase in the uric acid levels, and therefore it should not be given to people or patients who already have gout. Then it can cause hyperglycemia. Okay. Then we have other drug which is ezetimibe. Now, ezetimibe inhibits the special transporter NPC1L1 in the intestine, and what this does is it will block the cholesterol absorption. Again, the liver is going to have deficiency of this cholesterol, and again it is going to try to take the LDL from the blood or the plasma. Similar mechanism later on. So what is the main use of this drug? It is like an add-on. So when statins are no longer sufficient, so what you do, you add on this drug. So they are add-on to statins, right? In case of to decrease the LDLs. Major drawback here is steatorrhea. Okay. Yeah. Next one we have, very important, PCSK9 inhibitor. You just asked in the question. So this is alirocumab. So these are monoclonal antibodies. Evolocumab, and an antisense oligonucleotide is serine. So all these, any drug with serine, it is an antisense oligonucleotides. So what they do, they prevent the receptor degradation. So on the liver, we had these receptors for the LDL receptors. What is their role? They take up LDL from the plasma. So PCSK9 is involved in the degradation of these receptors. So if the receptors are degraded, then LDL will not be able to be taken up in the liver. So what they do, they inhibit this PCSK. So there is no degradation of these receptors. So therefore more LDL can be taken up. So again, ultimately what they're going to do, they are going to decrease the LDL levels. They are very, very good drugs in causing the decrease in the LDL levels currently. Again, these are add-on to statins, especially in people who have high risk of ASCVD. Then we have bempedoic acid, another very, very exam favorite these days. What is bempedoic acid? Now remember, so this is the liver, and in liver there is formation of cholesterol. So there are two steps for cholesterol synthesis. First step is this citrate, it converts into HMG-CoA, and then HMG-CoA then first to mevalonic acid, ultimately into the cholesterol. So the enzymes, two enzymes are present here. Here we have the ACL, and here we have the HMG-CoA reductase. So at this first step we've already done, that this step is targeted by statins, while the first step is targeted by bempedoic acid. So they inhibit the ATP citrate lyase. Ultimately, what are they doing? They are going to inhibit the cholesterol synthesis. So then the story is the same. So more LDL receptors are going to be, or they are going to be upregulation of this receptor. So more LDL is going to be taken up, and they decrease the LDL levels, right? So remember, bempedoic acid, it is a competitive inhibitor here of this particular ACL. Role, so again these are adjunct or add-on to statins. Okay, add-on to statins, or let's say the patient is not tolerating statin, or in statin intolerant patients. Next, we have the cholesterol ester triglyceride transport protein, CETP inhibitor. So first, what is the role of CETP? CETP, it helps in barter system of HDL and VLDL or LDL. What is this barter going on? Normally, HDL transfers the cholesterol ester and VLDL gives it the triglyceride. So this is done by CETP. So what will happen when HDL gives it cholesterol esters to VLDL and takes up the triglycerides? They are easily degraded. So therefore what they do, they decrease the HDL levels. While the VLDL ones, they are now becoming rich in the cholesterol esters, so they can become atherogenic. So we need to stop this. So what you do, you are going to block this. So these drugs rather, anacetrapib and torcetrapib, they are going to inhibit this process of CETP. So there's no barter system exchange system going to occur. So they are going to cause an increase in the HDL and they are going to cause a decrease in the LDL. Next, monoclonal antibodies against ANGPTL3. This is Ezetimibe, another very important drug. Remember this monoclonal antibody, which is ANGL3. So it is going to, what is the role of it? It is going to inhibit the lipoprotein lipase, and lipoprotein lipase is the enzyme which is important for the triglyceride degradation. So if you inhibit this enzyme, there will be increase in the triglyceride synthesis. So what this drug is going to do? This drug is going to inhibit, this ANGPTL3, and so this is going to protect it, or it is going to potentiate the effect of LPL. So there is going to be decrease in the triglycerides levels, decrease in the VLDL levels, and ultimately this VLDL levels is going to decrease in the LDL levels, right? So the target is the LPL. So they are involved in the regulating lipid metabolism. So metabolism of lipids, that is they are going to target here. So they are ultimately going to cause decrease in the LDL also and decrease in the triglyceride also. So remember this decrease in the LDL, they are doing this without involving the LDL receptor. So which drug group decreases the LDL levels without involving the LDL receptors on the liver? This is the drug. So they have no LDL receptor involvement here. Okay. So where to use them? They are used in familial hypercholesterolemia. Then we have MTP inhibitors, which is lomitapide, and we have ApoB protein inhibitor or antisense oligonucleotide against this, which is nevomersen. So both these drugs, or you can say this MTP and this ApoB, both are important for formation of the VLDL. Right, so if you inhibit this, there going to be decrease in the production of the VLDL. Ultimately, the LDLs are going to go down. So in case of decrease LDL or decrease LDL here, these are used, right? So MTP. So remember lomitapide, MTP. How does it? So it has M, T, and P. Metapide. So it rhymes with MTP. And we know mersens. These are your oligosense antisense oligonucleotides. Now, then we have other drugs which are not, you can say, clearly only against the lipids, but they work against like being a hypolipidaemic, as well as they have some other work function as well here. So we have this drug which is called as saroglitazar. Remember, this is a dual PAPR alpha and gamma. So here we know that it is going to work against what? So PPR alpha, PPR gamma. So with alpha, it is going to decrease this, the triglycerides. What about the gamma? And they are also going to inhibit, or they are going to increase the insulin sensitivity in the peripheral tissue. So they work both for lowering the plasma triglycerides and cholesterol, along with bringing down the HbA1c. So where they are used? They are used for diabetic dyslipidemia, right? So both lipids as well as the high blood sugar is also targeted because they improve the insulin resistance, and on the other hand, they are lowering the plasma triglyceride levels as such. Now we have another drug which is called as icosapent, which is an ester of icosapentaenoic acid. Now what are the functions of this? So they are going to decrease the VLDL production, number one. Then it also has an anti-inflammatory, number two, and it will stabilize the plaque. Because of this, it causes decrease in the oxidative stress. Remember, important here. So this icosapent, it decreases the cardiovascular mortality and it can be used as an adjunct to statin in ASCVD, especially if there is triglyceride levels are more than, if triglyceride levels are more than equal to 150. Okay, so these are the important hypolipidemic drugs. The major disadvantage or adverse effect which can be a possibility with this is that it can cause bleeding risk. So increase bleeding risk and atrial fibrillations. So this is an MCQ which was asked. A 60-year-old male patient with history of hypertension, diabetes underwent PCI stent placement for NExT last year. He is currently on aspirin, metoprolol, atorvastatin. Follow-up visit. His lipid profile was follows. So he has everything high cholesterol and LDL cholesterol, total cholesterol, triglycerides and HDL cholesterol is about 40. So which of the following drugs can be added to optimize his lipid profile? Ezetimibe, evolocumab, bempedoic acid, ezetimibe, evolocumab only, ezetimibe, gemfibrozil and bempedoic acid, or ezetimibe and gemfibrozil only. So remember, he has increase in the cholesterol level, there is increase in the triglyceride levels. So the first answer, all three drugs, ezetimibe, evolocumab and bempedoic acid, they are going to reduce the level of LDL cholesterol, right? Here. So because the cholesterol levels are quite high, you see the total cholesterol levels, LDL cholesterol, it is the best, and the patient has undergone a PCI stent replacement. So what is best to do is that we give all the three drugs together for the patient. So remember here, gemfibrozil, if we add, it is only going to target mainly the triglycerides. Here also triglycerides, right? So therefore, best is that we give all three drugs together. So with this, we finish the hypolipidemic drug.